Welcome to Medical Education Principles, Lesson 3, The Clinical Teacher, Smart, Patient-Centered Teaching. This is David Lee Gordon, Professor of Neurology. At the end of this presentation, the participant should be able to describe the 5 components of effective clinical teaching, that is, teaching at the bedside or in the clinic. To optimize clinical teaching and thereby optimize the experiential learning of trainees, follow the acronym SMART. S, set expectations. M, model positive behavior. A, affirm declared curriculum. R, repeat feedback. And T, target the audiences. We will discuss each of these items in more detail in the following slides. Let's start with S, set expectations. In the clinical environment, the instructor should establish structure to facilitate the learning and define the roles and responsibilities of the learner and all team members, including your role regarding patient care, teaching, and team leadership. You should also establish the optimal behavior and professionalism expectations. The instructor should prime learners for both patients and team rounds. This enables learner preparation for clinical experiences and encourages curiosity, growth, and question asking. Next is M, model positive behavior. Embrace being a role model. Realize that in the clinical environment as an instructor, you are always on stage. Observing doctor behavior is an essential component to learning how to be a doctor, and trainees are watching everything you do. To ensure that you don't slip up here, script your interactions. Use a standardized approach in all your interactions. And make sure you acknowledge, greet, and introduce yourself to everyone in the room, the patients, the caregivers, etc., both your name and your role. Explain using audience-specific and key positive words. Don't speak over your trainees, just as you would not want to speak over your patients. Use language they would understand and bring them up to a higher level. And the positive words enable the learner to feel better about their experience and want to learn more. Express gratitude and set expectations for learners, patients, and consultants. Consciously control your unconscious biases. Now, this is not an easy thing to do. That's why they're called unconscious biases. But if you can figure out how to avoid using judgmental language that sometimes is part of strangely enough, the declared curriculum, such as using the word patient denies. That implies that that you don't believe the patient. I'm not sure why we do that in medicine. The term abuse is clearly not ideal. It's no longer part of the DSM-5 verbiage to say, for example, alcohol abuse or drug abuse. It is a judgmental term. It is not a medical term. So use disorder is preferable. The word poor historian is a defensive term and also nonsensical. The historian is actually the physician or provider. The patient and the caregivers are people who provide the history. They are the history. They're not historians. The historian is one who records the history. So first of all, it's nonsensical to call a patient or witness a poor historian. But more importantly, it is defensive. And it paints the families and the patient in a bad light. It implies that the patient or families are either purposely trying to mislead you, or they are not intelligent, both of which are derogatory and inappropriate. Promote cooperation over competition. This is a big challenge. Most medical students spent their entire life, even as early as preschool or kindergarten, competing against other students in the academic environment. And the winners get to go to medical school. All of a sudden, when you become a physician, you learn you have to work in teams. And you have to collaborate with people. You have to cooperate with people. And it's not easy for folks who all their lives literally have been trained to be competitive. It is very important early on in medical school to try to change that dynamic. And it is important you as an instructor create an environment of cooperation and not competition. That includes avoiding interdisciplinary antipathy, meaning bad-mouthing other services. It may be appropriate to state that one service knows more about one thing than another. That's not antipathy. But irrationally saying bad things about other services or other physicians is not ideal behavior. Model humility. Admit your own ignorance and mistakes. That is really, really important. Because if you, first of all, you will grow more. You facilitate your own growth. But perhaps even more importantly, it facilitates the growth of your learners, because if you, as the instructor, admit ignorance or admit mistakes, it opens the door for them to admit that they don't know something or they made a mistake, and it enables them to grow more readily. The next component of the acronym SMART is A, Affirm Declared Curriculum. It is important for the clinical educators to be familiar with the declared curriculum, including the schedule, content, and learning objectives. You should consciously practice curriculum alignment, that is to say, teach and assess consistent with the course learning objectives. Teach the curriculum core content, that is to say, consistent with the declared curriculum, and never contradict the declared curriculum. However, you may teach supplemental material, but it is important to inform learners when you are doing so. Inform learners when you are teaching supplemental material beyond the declared curriculum so they can recognize it as such. The learners should not be tested on the supplemental material, but many learners really appreciate the extra information or skills that are taught. So it's a good thing to do this supplemental material teaching, but do so consciously and enable the learners to be conscious of that fact. The next component of SMART clinical teaching is R, repeat feedback. Give feedback face to face, not behind the back of the learner, and identify the interaction as feedback so the learner recognizes, in fact, that it is feedback. It is amazing how often that happens, that they don't recognize it is feedback until you tell them. You should distinguish generalizable feedback from personal feedback. It is actually preferable to give generalizable feedback in front of the group so that everybody in the group can learn from different experiences or different even mistakes. But if it's a personal issue and you think that the performance of the learner needs improvement on a personal level that is not generalizable to everybody else, give that feedback privately. It is not appropriate to give private feedback in a general environment. Include both achievements and opportunities for improvement using a transparent mutual learning approach. Avoid the sandwich approach in which you say, well, you were pretty good, but this was bad, but then you're pretty good. Just say the good and the bad, the achievements and the opportunities. That's all, just the two types of feedback. You can facilitate deliberate practice by promoting a growth mindset as opposed to a fixed mindset. So what I mean by that is emphasize effort and self-improvement over talent and personality, because assessment drives learning. Assessment drives learning. So when you give them the feedback, even though it's not graded feedback, just we call it formative assessment, the feedback assessment, that still drives learning. If they know they're being given feedback on something, they'll behave better next time, or perform better, or know more, etc., etc. The growth mindset also promotes cooperation over competition. The idea is not to be better than somebody else, it's to be better yourself. And in general, SMART goals, this is a different SMART acronym, not developed by me, developed somewhere else, in which someone created this acronym to clarify the type of goals you would like to establish for the learner. Have to be specific, measurable, attainable, relevant, and time-bound. In other words, practical. You have to be practical goals. Always provide a rationale for your feedback and advice. And very importantly, at the end, request feedback from the learner. and take it positively. The learner is more likely to take your advice more seriously when you take their advice seriously, and in fact, even seek their advice in the first place. The final component of smart clinical teaching is T, target your audiences. Consider the learner training level and flow. Once again, flow is the state of optimal experience in which a learner perceives his or her skills match challenge difficulty. You should vary your teaching and expectations based on the learner experience or level. You're not going to ask a beginning clinical medical student, for example, to manage a patient with epilepsy. That's maybe for the senior resident. But you might ask the beginning medical student to recognize a patient having a seizure or how to take a history in patients with seizure. Use learner-specific teaching strategies. And these include priming, preparing a learner for a task, modeling, explaining your decisions and actions. Think out loud. It is not good enough to say, this is our plan. You must say, this is our plan because. Let me explain why I have chosen to give this medicine versus that medicine. Let me explain why I spoke to the family this way and not that way. Modeling. Explain all your decisions and actions. That leads to tremendous growth by the learner. Personalization. Make situation pertinent for the learner, based on learner background and interests. If a medical student says, I want to go into OBGYN, then throughout the clinical experience, when there are moments when clearly certain issues are more pertinent to that field, then you make sure you say, well, just like you'd like to do OBGYN, this is very important for people going into OBGYN or ophthalmology or ENT or pediatrics or psychiatry or whatever it is. Personalize the training. Anecdote. This gets a bad rap in some places, anecdotes, but anecdotes can be very powerful. Tell stories consistent with evidence or best practice for improved understanding, retention, and recall. This simulates experience. When you tell a story about a patient, in other words, case-based teaching, the learner then encodes it in their brain as an experience. It's as if they had the experience and they actually remember it better. Just make sure that the anecdote is consistent with evidence or best practice, not the opposite. And then dogma. Dogma is really important. The younger or less experienced the learner, the better to use dogma. This is maintaining simplicity and consistency. And you do have to vary the complexity of what you're talking about for the levels of the learner, obviously. Very different from between a beginning medical student and a continuing medical education, for example. Very different. In summary, use smart clinical teaching for optimal experiential learning. Set expectations. Model positive behavior. Affirm declared curriculum. Repeat feedback and target audiences. When setting expectations, establish structure. Define responsibilities and optimal behavior of learner and all team members. Prime the learner and encourage question asking. To model positive behavior, embrace being a role model, control biases, promote cooperation over competition, model humility, and admit ignorance. Affirm declared curriculum, know the declared curriculum, supplement and never contradict the declared curriculum, and identify when teaching supplemental material. Repeat feedback. Perform feedback face-to-face and include both achievements and opportunities. Emphasize growth and facilitate deliberate practice. Provide specific and attainable goals, provide rationale, and respond well to feedback from the learner. And target your audiences. Consider the learner training level and flow. Use learner-specific strategies, including priming, modeling, personalization, anecdote, and dogma. This concludes Medical Education Principles Lesson 3, The Clinical Teacher. And at this point, you should be able to describe the 5 components of effective clinical teaching, that is to say, teaching at the bedside or in clinic. Thank you for viewing and listening to this presentation. This is a DLG Insight production. Innovative neuroscience ideas and thoughts on education.